Welcome to our webinar training on implementation of therapeutic foster care services, provider and county partnerships. This webinar is provided by the Department of Healthcare Services, DHCS. I am Kern Kurosaki, consultant with the California Institute for Behavioral Health Solutions, CIBHS, and I will be facilitating today. I am joined in the room by Teresa Castillo with DHCS, Kim Suderman, consultant for CIBHS, and Kelly Bitts, Senior Program Coordinator at CIBHS. First, a few housekeeping items before we start. We are recording the webinar in order to make it available later on the CIBHS YouTube channel. For those of you who are joining the webinar live today, you may notify us of any technical difficulties at your end through the chat box, and we will try to address it immediately. We ask that you please use the questions box to submit your questions. Due to the number of attendees, we will not be able to unmute everyone so that you can ask your questions aloud. It will just cause too much background noise. So instead, we ask that you please type your questions in the questions box. You should be able to find that on the right-hand side of your screen. You may do so at any time throughout the webinar, and we will address your questions intermittently during the webinar and also at the end. So a bit of background and history. The development of therapeutic foster care, or TFC, services in California goes back to 2011 with the KDA Settlement Agreement. In December 2011, the state of California entered into a settlement agreement of the class action lawsuit KDA versus Bonta. As a result of the KDA settlement agreement, intensive care coordination, or ICC, intensive home-based services, IHBS, and TFC services are now available to children and youth who are under the age of 21, eligible for the full scope of Medi-Cal services, and meet specialty mental health services medical necessity criteria. While the KDA settlement agreement only concerned children and youth in foster care or at imminent risk of placement in foster care, membership in the KDA class or subclass is no longer a requirement for receiving medically necessary ICC, IHBS, and TFC services. This means that a child or youth need not have an open child welfare or juvenile probation case to be considered for ICC, IHBS, or TFC services. There are a number of resources that we want to highlight for you. To support the implementation of TFC services, DHCS put out two important resource documents. First, the Medi-Cal Manual for ICC, IHBS, and TFC, 3rd edition, which was updated in 2018 to incorporate TFC services. And the second document, the TFC Training Resource Toolkit, also made available in 2018, was developed with extensive input and guidance from CDSS and also from the TFC Expert Work Group, which was a subcommittee of the TFC Implementation Committee. DHCS has also provided several previous webinar trainings like this one, and in 2019, DHCS completed its 3rd round of regional convenings throughout the state for county behavioral health, county child welfare, county juvenile probation, and provider agencies that were in the process of collaboratively planning, building, and implementing TFC services and other children and youth services for foster youth and children in out-of-home placement. All of these materials, including recorded webinars and downloadable slides, are available on the CIBHS website at cibhs.org. And now we are interested in learning who is in our audience today, so we have a couple polling questions we would like you to respond to. First, please tell us the type of organization you represent. County Behavioral Health, County Child Welfare, County Juvenile Probation, Foster Family Agency, statewide agency or association. And we'll just pause briefly for you to enter in your information. All right, thank you. You also might be interested in who's in the audience today, so how about we share? County behavioral health or mental health, 49%. County child welfare, 15%. County juvenile probation, 2%. Foster family agency, 25%. And statewide agency or association, 9%. Thank you. So next, please tell us where you are in the process of implementing TFC services, providing and billing for TFC services, starting to provide TFC services but not yet billing, contracted with an MHP or contracted with the provider if you are the MHP, or very close, in the planning process or contemplating TFC services. Again, we'll pause briefly to allow you to answer the question. All right, thank you. So, providing and billing for TFC services, 7%. Starting to provide TFC services but not yet billing, 12%. Contracted with MHP or provider or very close, 33%. In the planning process, 30%. Contemplating TFC services, 18%. So again, thank you for participating in our poll. Let's talk about what we are going to cover in our webinar today with you. We understand that provider and county partners are working in collaboration to plan, build, and implement TFC services, and that every county is in a different place in that process. We are also aware that there are recurring questions such as around parent recruitment and training, contracting and reimbursement, documentation and supervision, and so on. And these are real and challenging. So today's webinar has been designed with those questions and challenges in mind. We are pleased to feature presenters from ChildNet Youth and Family Services, Kern Child Protective Services, and Kern Behavioral Health and Recovery Services, or Kern BHRS, who have agreed to share their experiences and their journey building and implementing TFC services together in Kern County. Although there is no one-size-fits-all, we have asked our presenters to share the thinking that went into the decisions that they made, what has worked out well and what hasn't, the lessons learned, what they might have done differently, where they are now, and future goals and challenges. They will touch on the following areas: planning for TFC services, TFC parent recruitment and training, contracting process and Medi-Cal certification, supervision and support for TFC parents, referral process and child and family teams, and program outcomes and lessons learned. Our presenters for today are Deborah Burris-Garofalo, North Regional Director for ChildNet Youth and Family Services, Macy Albertson, Program Specialist with Kern County Child Protective Services, Brenda Story, Unit Supervisor for Continuum of Care Reform with Kern BHRS, Heather Williams, Recovery Specialist 3 with the Quality Improvement Department at Kern BHRS, and Jenny Sill, Children's System of Care Administrator with Kern BHRS. Thank you, all of you, for joining us from your offices in Kern County. We are so grateful to you for sharing your time and knowledge with all of us today. And with that, now, I'm going to turn it over to you, Jenny.
Good morning, and thank you for letting us be here. We thought we would just start out by just giving a little bit kind of a platform of where we are in Kern County and kind of what we've kind of done to begin to plan for the continuum of care reform. So we currently have two different TFC programs in Kern County. One is the Treatment Foster Care Oregon model, which we do to Fidelity. We've been doing that model since about 2003. And that really has given us some experience, even though it's a bit different how we're implementing the TFC through ChildNet. It does give us kind of a stage to jump off of as we moved into implementing with ChildNet. So ChildNet will be our second program that we have here now. And that's the program that we're going to be basically focusing on today. So next slide. So in part, what I think about it is kind of when we began this process and kind of where we started at. So I always think about whenever you're designing something, you have to think about who is the customer. And obviously, first and primary are going to be our children and our families. We wanted to make sure that we were designing something that was really going to help families in their recovering and reunification when that was possible. So that really is always primary. One of the tenets of treatment foster care, the Oregon model, is ensuring that as kids are entering into TFC, that there is kind of a long-term plan, that there's somebody to unite with, that there's a family that they can go to, or long-term foster placement. And so we're trying to pull that forward also as we implement this model, because we think that really is key to success in terms of how we're doing our planning. Secondly, really important is our placing agency, Department of Human Services and Probation. We know that continuum of care has brought lots of changes to all of us, and you know, this is kind of hopefully one additional option that will be helpful to our placing agencies in terms of the treatment that we're providing. So we started meeting in 2016 with county partners. So we had Department of Human Services, Probation, Education, and Behavioral Health, and really had kind of a series of planning meetings to look at kind of where we wanted to go as a county with the continuum of care reform, what kinds of things that we needed to do to get ready. From the behavioral health side, there were three components that we thought were really important, not just for TFC, but really for how we develop our entire system. So the first was looking at making sure that there is good access. So one of the things that we do is that we do universal assessments for youth that are coming into protective custody. Our expectations of ourselves and of our providers is that we always are trying to be proactive with kids. And so part of what happens is when you're doing that assessment, it gives us the ability to really kind of begin to know our kids quickly so we can ensure that we're providing the right level of care for them. The other thing that we did in terms of access is we integrated a social worker, actually two social workers, and a probation officer into our children's systems. And that really helps, again, to give the access to help make sure we're identifying the kids that need that extra support. Then the second piece is that continuum of services. Again, you know, wanting to make sure that we give the right services for kids, that we really are looking at what their needs are. And that could be using an evidence-based approach. It could be doing ICC. It could be doing other kinds of RAP type services, weekly therapy, really kind of looking at what the needs are, and then moving from there. And often as kids are needing extra support, that'll mean the TFC services. And then lastly is looking at systemic changes in development. So we really wanted to look at how we're integrating things. One of the things that I think was important is looking at how we're working cross systems with the integrated core practice model. So ensuring that good coordination happens. I think primary is looking at how we are engaging families, making sure families feel like there is a place for them in the process and that we're hearing what they're saying. And then I think also looking at, unfortunately, our kids sometimes will move quite often as they're going through the system. And we wanted to make sure that whenever possible that we kept therapeutic bonds. And so how we set up our system is we work really hard not to move kids around from provider to provider. Kern County and Bakersfield is small enough that you can get most places here locally in Bakersfield, which is where the concentration of most of our foster care kids are, within 15 or 20 minutes. And so we really try to work toward that system integration and maintaining the therapeutic bonds that we have. Then the next piece was looking at what our capacity was. And that was really actually quite interesting. It was just really a lot of tracking, looking at, how many of our kids that we thought might use a TFC service, how many of our kids that were in group homes at the time, now STRTPs would be doing some kind of step downs. DHS did a fantastic job and organized some case reviews in the very beginning of kids that were in group homes, and really began to do some concentrated planning for those kids in partnership with probation and behavioral health, to figure out, what did we want the step down plans to look like? What did we want for our kids in terms of permanency for them? I think, and don't quote me on the numbers, but I think we had close to 80, maybe a little bit more than that when we started. And I think at this point, we have about 30, group home kids on the DHS side. So there's been a lot of good work around that. And TFC, I think, is a piece of that step down plan for these kids. And then lastly, we looked at our RFP process. We really followed our normal process for releasing the request for proposal and asking for folks to submit their proposals. Again, we were looking at, how did we integrate services into our overall system of care? We didn't want a provider to work in isolation. We really wanted to make sure that whoever our new provider would be, which turned out to be ChildNet, that we were that we would take on a team approach, that we would work with our whole system. We also did a lot to share the RFP process with our partners, with DHS and with probation, and continue to do that education about kind of what this service is and how it can benefit our kids and families. And then lastly, I don't remember if it was right before or during or after, but very close around that RFP time, we also did several trainings. The first was an overview training on mental health that we invited potential STRTPs and our TFC provider to, and just really kind of gave a walkthrough of the mental health system. I think if you are working primarily as our group homes were, and I think our FFAs from that side of the house, the mental health side of the house is very different. And there's a lot of things to learn. And so we worked on that. We gave a kind of general training on that. And then we followed up with a how to become a mental health provider and how do you develop a mental health business plan, because the business of mental health is, again, very, very different than the other side of the house. And then from there, we followed up with 6 or 7 other trainings for our TFC provider, just looking at things like you know, evidence-based processes, looked at DBT trainings, TBS trainings, crisis response trainings, just kind of some basic trainings that we provided. And with that, I'm going to put it over to Deborah.
Good morning. I'm Deborah Bursker-Ruffalo with ChildNet. And so we decided to become the TFC provider because we had been providing ITFC and ISFC services for many years in our other regions. When Kern County decided to RFP the TFC services, we believe we had the expertise and we believe we had the experience with our other regions in behavioral health to become a TFC provider in Kern County. We were already an ISFC placement provider here in Kern County prior to providing the therapeutic foster care services. So we did integrate the TFC services with our ISFC program by training all of our ISFC resource parents at the therapeutic foster care level. So these resource parents can take an ISFC placement, but they're also able to provide TFC services with those placements. So currently we have 20 resource parents that are providing therapeutic foster care services. We became aware that when we started doing the TFC contracting process, that we immediately began to recruit our current resource parents that had already been providing services to children in ISFC placements or some of the more difficult and challenging placements. And we realized that those experienced foster parents would have much more of the expertise and patience needed to work with the TFC population. So those are the resource parents we started reaching out to and began the training. Our approach for TFC parents that we use, we are leveraging our ISFC trainings along with the Together Facing the Challenge Therapeutic Care Resource Toolkit to train our resource parents. Some of the challenges that we've had with recruiting some of our resource parents was basically overcoming the fear of regular foster care versus intensive services foster care. So a lot of our discussions with our resource parents were things like, you've already had children in your home like this, they just weren't identified as TFC, language that we encouraged our resource parents to begin the training and letting them know they already had the skill set. But I think that label was just very scary for some of our resource parents initially. Some of the challenges we've had with that is that our resource parents have a lot of constraints. The training hours that they need to have prior to taking a TFC placement, a lot of them work. They have other children placed in their home and their own biological children. So that can sometimes throw challenges for them to attend the training. And we also had to train our resource parents at the electronic health record, which is used by Kern Behavioral Health. That did cause some challenges with our resource parents who were not used to using a computer, who were not tech savvy. So we spent a lot of time with our team going in and training them in partnership with Kern Behavioral Health. I'm going to hand it back over to Jenny.
So looking at contracting and reimbursement rates. So again, we followed really the standard process that we had for contracting here. As we wrote the contract, though, we really were looking at how do we help ensure that there is integration across our system. We wanted to make sure that you know, kids were able to hold on to any therapeutic relationships that they already have, and so we wrote that into the contract. This is also kind of a pivot point for our entire system because we've always worked pretty well across across systems and within our own system, but it does take probably some more work for our geographical providers as they're coordinating now as as TFC now as an adjunctive services to what they're already doing. Looking at how we determine the daily rate, that was really kind of a negotiation process with a little bit of math. So basically what we knew is that we wanted the majority of the services in this contract to be therapeutic foster care services. And so we set that standard to be 60% would be TFC, and then 40% would be other specialty mental health services. And then in terms of how we figured out kind of that rate that we would do for TFC, we really just kind of worked our way through it, looking at, we have 365 days, and of those, we had budgeted to have 10 slots for TFC at this point, which we've now actually increased to 20 slots in Kern County, but we initially started with the 10. And then from there, we just kind of worked our way through until we were able to come up with a projected daily service. How many hours did we think that they would on average be billing? And then from there, we looked at like per minute rate. And then from there, we allocated it out and then had our daily rate. I think it's like $65 or $66, somewhere in there. So that was kind of our process.
All right. We have a couple of questions that came in. And so we'll go ahead and read the first question for our presenters to answer. What assessment tool is used to assess need?
So we currently have our behavioral health assessment that we look at from the behavioral health side, but I know on the DHS side,
we're really, from the social work perspective, we're really looking at what comes out at our CFTM. So when we're at the CFTM meetings and we're discussing, when we have mental health at the table and we're discussing what's happening in therapy, what happened on the CAMS assessment, what has happened in previous placement, and what are we looking to accomplish, that's really kind of setting the tone for what service we should look at for placement, whether it's like ISFC, TFC, TFCO, STRTP. So there isn't a paper assessment aside from that we are looking at the CAMS, but we just really are coming together as a team and making that decision.
Okay, thank you for that question. The next question. We operate an STRTP, FFA/ISFC, and THP program for children transitioning from STRTP into ISFC with TFC. Are TFC services impacted if county of jurisdiction waives presumptive transfer?
Those were a lot of initials. So I think you're asking, like, if a child needed TFC in our county, would we provide those services? Is that what the question is?
I think what's being asked is if the child has been presumptively transferred if jurisdiction is waived, so presumptive transfer is waived, how does that impact TFC services? So depending on which end you're on, maybe you could respond from both perspectives. If you are the host county and TFC and presumptive transfer is waived by another county, then how does the provider, how does ChildNet, how do you provide services because the child is in your county, and vice versa if presumptive transfer is waived and your child from your county, from Kern, is placed in another county, but it's decided that the child needs TFC. So maybe you could try answering from both perspectives.
So I can take the first perspective very quickly because it's an easy answer for us at this point. We have not yet had a waiver of presumptive transfer. So for us sending children out, we haven't crossed that bridge. So from that, I don't have an answer for you, but coming in.
Yes, from the perspective of ChildNet, there's a process that we go through with, and Macy will talk about it a little bit later, where we have a committee of folks who determine best needs and best fit for the child. So if we did receive a TFC referral from an out-of-county child, there's no reason why we wouldn't be able to provide those TFC services.
Okay, thank you. The next question, is that daily rate to the agency or to the resource parent?
It's to the agency.
And then an additional related question, what percentage of that $65 daily rate goes to the parent versus to the FFA? Actually, that's the same question, isn't it? So it goes to the agency. Did you want to expand on that?
So we pay our resource parents about $25 per note per day. So it's about 38% of the ISFC rate because our resource parents are paid the same rate for ISFC as they are for TFC as far as the stipend. So that percentage is about 38% of that. So they do get about $25 per note per day. So in a week's period of time, they can do 7 notes, for example, and it can add up, over a month's period of time.
Thank you so much for that clarification. Let's see, another question was for Deborah. What was the name of the training approach that you said you used to train parents? Would you say that model's name again for us, please?
Sure, it's called Together Facing the Challenge. It's an evidence-based.
All right, thank you.
Model.
Okay, we'll take one more question. If the child is receiving TFC services, is transferred into relative placement in an adjacent county where we don't have an mental health contract, can we still provide TFC for that child?
I think that would be very difficult for us to do that through ChildNet at that point.
Because most likely the relative is going to get certified through the county system, the RFA system, and the ChildNet homes are certified through the FFA. So that's not going to be a TFC placement. It's not to say that we can't add services to stabilize the placement, but it would not be the TFC model.
This is Kim Suderman again from CIBHS. Just to add to that, I think that's where the opportunity to provide other specialty mental health services to the child would probably be more logical once that change happens.
Yeah, 100%. Absolutely.
Okay.
So I am going to take one more question because it is related to this conversation about training parents as well that you just presented on. So for parents that are trained as ISFC and TFC, do you have youth who are receiving both ISFC and TFC services?
We actually can provide both services. So we can have a child. We've had children placed in our homes that were receiving ISFC services. And then we bring that back to the committee because the behaviors or the mental health issues become so great that we need a higher level of care, a higher level of treatment. So we do come back to the committee and our team gets approved to provide TFC services. So we actually will have our TFC team go into the home and begin those services as well for the child.
Okay, thank you. And thank you to all of you who are participating by sending in your questions. And we're going to go ahead and continue with the next slide.
So this is Heather Williams with the Quality Improvement Division. So for our Medi-Cal certification, We just kind of follow the same process for whenever we do any kind of certification with our system of care. We provide the contractor, we provide ChildNet with an overview of the site certification tool that is utilized. We also do some walkthroughs to help them set up their lobbies and get them prepared for all of the required documentation that is needed, postings that are needed. We ensure that they have the policies and procedures that meet all of our standards in place, and the language in there is appropriate. And like I said, we do a mock walkthrough where we can provide them with feedback, and we've done, I don't know, Deborah, how many times did we come out there?
2 or 3.
Yeah, so we have a pretty good team of people that kind of come out and help with the site certifications. And next slide.
Okay, this is Deborah again. So the contracting process for us was that Kern Behavioral Health put out the Rfp process, of course, for TFC services. And ChildNet already had, as I mentioned before, a wealth of experience in our other regions with Medi-Cal certification. So the expertise of those other staff in those regions were helpful in giving guidance and preparing for the writing of our policies and procedures for Kern. Once we put together a draft of the policies and procedures, Kern BHRS had a team of their quality improvement, which is what Heather's talking about, meet with us several times to walk through the process and assure our policies and procedures were up to speed. They provided a lot of technical assistance for us and support. It was a very collaborative and educational process. Some of the things that were challenging for us was the time that it took for the fire department to actually come out and provide the fire clearance. That probably took the longest to complete. But overall, we had a lot of assistance and support from Kern BHRS. Next slide. Is that okay? So one of the things that we had to deal with was the number of time our TFC parents were provided supervision and factor in the time of how our team was going to be able to go out and provide that support. So the TFC parents are set up for supervision twice weekly by our clinician. The clinician arrives to each home. They focus on the TFC treatment plan completed in conjunction with the foster child therapist. The clinician splits their time during each week in the resource home, doing foster parent skill building, practicing role modeling. The clinician also spends time assisting the resource parent when entering those daily progress notes. And again, that's in the Kern Behavioral Health electronic health record. So our clinician spends on average about 2 hours per home per visit with the doing the training and also helping them put the notes into the EHR. Our TFC parents are really treated as a professional and as equals at the table as a TFC team member and employee, if you will. Their access to the electronic health record is treated as an employee. However, they have limited access to the EHR due to confidentiality and HIPAA. So that rate that we talked about earlier that our resource parents receive for their daily notes, again, was based on a percentage of the ISFC rate. And again, it's about $25 per note per day that our resource parents complete, and our TFC team is in the home weekly helping them complete those notes. And next slide.
Actually, no, let's see right here. Just to kind of expand upon the referral process, something that we at Child Welfare determined was necessary was a little bit of a flexibility. We have a lot of turnover, and in an effort to make sure we're all doing what's in the best interest of our children and families, we wanted to make sure that we weren't stifling ourselves by being too bureaucratic in our referral process. So that is something that our Interagency Placement Committee, our IPC, is called SMART. So you'll see that referenced on your page, and that's what that is. Our SMART team is our Interagency Placement Committee. So we meet every Thursday, and we'll discuss cases that are high risk or cases that will likely be referred to TFC, TFCO, or RAP services, and we discuss as a team, which is mental health, ChildNet, the mental health providers, and the Department of Human Services, as to which path we think is best for the child. So if there's already been a CFTM, then we'll revisit that process through just an informal meeting and informal communication to make sure that everybody's on the same page as to what the child's needs are. If we've identified that prior to a CFTM, then all of the players or prospective caretakers can be present at the CFTM, and then the CFTM process is more whole. So we've just decided that in order to be successful, we've just really been flexible, and we've maintained a high amount of communication throughout the agencies, and that's been very beneficial to everyone.
So this is Kim again from CIBHS. So we've received several questions with similar information requested. The first one, let me just say that the fire clearance, there's several questions about fire clearance. The fire clearance is not done on each house because the house, each home is not Medi-Cal certified. The site where the agency is located is the Medi-Cal certified site and the fire clearance. I just want to check in to see if, Jenny, you want to add anything to that?
Yeah, that's
correct.
That's correct. Here in Kern County, we have two fire departments, the county and the city, and that's a history we hear a lot about. Getting the fire clearance takes a bit.
Yes, that does take the time, so that's one of the important things to get started right away. The second group of questions is in relation to the Medi-Cal site certification itself, and that is conducted by the county. In any county, the mental health plan has a contract with the Department of Healthcare Services to provide the Medi-Cal site certification of all of their organizational providers, and DHCS conducts all the Medi-Cal site certifications of any county-operated programs. So in any county, it will always be the county conducting the provider's site certification.
Correct.
We also have a question related to documentation. So can you say more about what it looks like for the clinician to help the parent enter the notes?
Sure. So our model is that our clinician basically takes a laptop to the home. We go into the electronic health record. The resource parent has their own ID, so they're able to log in. Our clinician sits there with them, and they kind of talk through what the behavior was or what the intervention was that they provided. They enter the note together. They discuss and make sure that the resource parent understands, what the connection was to the treatment. Once the note is entered, our clinician is able to come back to the office and approve those notes. And then they go through a process through Cerner where we are able to kind of bill for those notes at the end of each month.
And what other duties do your clinicians have on top of the 2 times a week supervision of the parents?
So our clinician also provides training to all of our resource parents. When they're in the home, role modeling and practicing with the resource parent, any type of treatment model. Again, the TFC treatment plan came in conjunction in partnership with the therapist that's assigned to the child. So they're constantly in communication on a weekly basis with the child's therapist. They're participating in the weekly CFTMs. They're coordinating services with the county social worker, with the therapist, and with the resource parent to make sure everybody's on the same page and that the treatment model is being developed, implemented to fidelity. And also making sure that the resource parents have any of their questions answered. Sometimes they even help out with finding respite for the child. They're just in the home and basically they're as a confidant to the resource parents when they're struggling, encouraging them to, self-care is a big part of it. Making sure our resource parents are still engaged with the child and assessing their stress levels is a big part of it as well. And again, our whole purpose is to make sure the child stays in placement, and we are hopefully reducing some of those behaviors and some of those episodes with our team in the home on a weekly basis.
And then I just want to, this is Kim again, just going back to the question in relation to helping the parents. The question was also really a part of, so I think you answered the part of how the parents enter their note into the EHR. But the other part of it, so let me follow up with that. And so they don't ever just go into the EHR and see other parts of the electronic health record, is that correct?
That is correct. Our clinician sits there with them side by side just to enter. They go into the portion where they enter their daily note, and then they are actually out of, once they enter the note, they exit the program and they take the laptop with them. So our resource parents never have access to other information on that client or on that child.
Okay. And then the other part of the earlier question was about the clinician's role in the chart. What is the clinician documenting in the electronic health record?
So our clinician basically goes in and documents any of the interventions that are provided by the resource parent and also themselves. We also have a coach that goes to the home on a weekly basis. So the clinician is the lead to our coach who works directly with the child. So the clinician is documenting any of the mental health services that are provided, that they are providing as well, coaching the resource parent, any interactions they have with the child, anything that they're doing with the clinician, that's the assigned therapist with the child. Our clinician is documenting all of that in the electronic health record.
So remembering, if you go backwards, that we have, the 60-40 split, and so they may be doing other specialty mental health services in addition to the supportive work that they're doing for TFC.
And then they would document that separately, correct?
Yes, correct.
Yes, okay. And then another follow-up question in relation to the co-signing, and of course, in an EHR, it's a little bit different. So when the licensed clinician is with the parent in the EHR, can you describe how the co-signing works and is addressed? And are there times where the clinician might ever not co-sign, or how does that work?
So the resource parent has to approve their own notes daily that they enter into the EHR, and our clinician's role is to make sure that those notes are accurate and that they're actually to Medi-Cal fidelity. So our clinician approves those notes after the resource parent enters the notes. If there's any questions that the clinician has or any clarification, they can actually go back to the home and revamp the note or clarify on the note if they felt like it needed a little bit more Medi-Cal fidelity in it. Sometimes our resource parents, because they're not, master's level, bachelor level resource parents, sometimes they provide a service and they need help kind of describing what it is that they did. So they actually have a really good handle on the intervention that they did, but sometimes our clinician's role is to help them understand how they connect that to the treatment plan that was actually developed by the child's therapist.
Great. So authorizing the note in an EHR is akin to a co-signature in a hard chart record, correct?
Yes. Yes.
Okay. All right. Thanks.
So let's see, we have some other questions here in terms of, the clinician's time and how that's billed. And so if you could go back to that, you did talk about how the clinician's role, some of it is with the TFC services and then some is with other specialty mental health services. So could you elaborate a little bit about how that clinician's time is billed?
So this is Heather. So for the clinician, that 60-40 split, so the 40% of specialty mental health services that the therapist and the coach is providing, it's entered in just like any other by-the-minute specialty mental health services that are provided at any of our outpatient clinics. So if there's a crisis, the therapist could be claiming a crisis services and documenting that crisis services for however many minutes it's provided. They also are collaborating with the geographic provider and coordinating services through that also, which also contributes to the specialty mental health services that provider is getting, or that client is getting from the geographic provider and the the therapist or the coach from ChildNet.
All right, thank you for all your questions. Why don't we go on with the presentation?
Since we've been talking about documentation, if you go forward 2 spaces or 2 slides, I can talk a little bit more about our process for training and stuff like that. So for us at our QID department, our documentation team, we actually began doing training with the ChildNet staff, the therapist and the coach, or the clinician and the coach, prior to the resource parents onboarding into the services. So we actually trained them on specialty mental health services, and then also we began training them on the TFC process, so that when the resource parents came along or came on board, that they were aware of the process for the TFC and the documentation that was required. We also, for the resource parents, so that they could help, as Deborah had explained. We also do trainings within the EHR, and those are hands-on trainings. We keep the groups kind of small at our computer lab. I think we try to get about 5 parents at a time, and so in there's the clinicians from Kern BHRS and our trainers. There's the clinician from ChildNet that are also in that training, and so everybody's doing really hands-on with the computer. So that kind of helps with some of that nervousness that Deborah had mentioned. Our progress note. So within our EHR, we have actually created a progress note form that is specific to the TFC services, and it's actually driven by another form that we've created that's our ICC and IHBS plan. So the plan that's done at the CFT with the geographic provider and the other people that are involved within this client's case, they develop kind of this outline of what behaviors and symptoms the child has and what time of the day they're having them. So we broke it down by morning, evening, or midday, evening, and afternoon, and bedtime. So that will help the resource parent know when those problems are going to be happening, or kind of be prepared for what they can do to help with that child based on the collaboration from the CFT. And yes, we have shared some of this documentation with other counties already. So if there's anybody who wants any information about that, feel free to contact us. Our monitoring process that we've kind of done with them, we started out very small. We started out very small, where we did actually review everything on a daily basis and gave feedback to the FFA on documentation for both the specialty mental health services, and then we expanded that same process back out to the TFC parents also. So we began by doing monitoring on a daily basis and giving feedback. Then we moved to a weekly basis, and then we've moved to like a 2-weekly basis, every 2 weeks. And we're now actually just incorporated that into our quarterly reviews, where we're not giving individual feedback anymore to them, because they're already all up and running and they're doing great, and their clinician, the ChildNet clinician and coach know what to look for and know how to give feedback to the parents.
Some of the main challenges that we experience with our resource parents completing those TFC daily notes was comprehension of the process and timeliness of completion. So we've had a few bumps around that, but we again went in and provided more training to our resource parents. We also incorporated the coach going to the home and also assisting with completing the notes with the resource parent. Still have to be final approved and okayed by the clinician, but that was one way we kind of assisted them with being able to get the notes done in a timelier fashion, because that is a little bit of a challenge for them when they have other responsibilities on the daily basis in their home.
Next slide. Hi, this is
Before we go on to the next slide, we have several questions here that we want to try to address.
So one of the first ones is in relation to this clinical supervisor doing going out to supervise the parent. And I know you said earlier that they are both supervisor, but they're also can provide Medi-Cal specialty mental health services themselves. So how are they billing? They're billing for that, we clarified earlier. And then how are they dealing with their time doing the supervision of the TFC parents? Are you billing any of that, or is all of that built into the rate as part of their administrative time?
Yes, that's built into the rate for the administrative time. We don't bill any of the supervision that they provide. Sometimes they can be out there for a couple of hours. Sometimes it can be just a few minutes. But again, a lot of times resource parents just have questions,
Right.
Technical questions that they need assistance with. So that's correct.
Great. And then one of the other questions is in relation to the other mental health services. They're asking just if they're provided through the TFC parent. So is the child only receiving TFC, or are many of your kids also receiving other specialty mental health services besides TFC?
Yeah, so they receive TFC obviously through the resource parents, and then other specialty mental health services through either ChildNet staff, or if there's a geographical provider that's serving the child, they may get services there also.
Okay, great. Thank you.
And then we have a question related to understanding, the FFA and the TFC provider. Where are the kids enrolled? So would you mind clarifying how, just kind of the terminology, and clarify that for us, for our audience? The question is, is ChildNet both FFA and TFC provider? Is ChildNet supporting kids enrolled in various FFAs? So I think that you could provide an answer that can help clarify that one for us.
So ChildNet is both an FFA and the TFC provider. So we support our resource parents that actually have the children placed in their home. I'm not sure if the question is, do we provide TFC services to other FFAs, if that's what you're asking. But the answer is no, we only provide the TFC services to the children placed in our FFA.
Very good. Thank you for answering that question. Let's see. We have a question for the county. Are there any youth in TFC who are not foster children?
Yes. Well, actually, I take that back, because we do have probation children as well. So we have wards or foster children, and that's it at this point.
Yeah, but we don't have any other non-foster care kids yet. To come still.
And then I want to just, were a couple of questions in relation to the Medi-Cal certification, so I do need to back up, in relation to the mode of service and the what's submitted to the state. And so I'll just quickly clarify that currently there is no TFC checkbox on the transmittal form that the county submits to DHCS once they have Medi-Cal certified the TFC program. However, that is in process of being updated. So that will be included in the future. However, today and in the next few weeks, you will still have to, as the county, when you submit your transmittal to DHCS, handwrite in on the document that you are Medi-Cal certifying the provider for TFC, either only or as well as whatever other services you have checked off.
Correct. And make sure that you've written it in, not typed it or been fancy with your filling it in. They want it handwritten in.
Thank you for that clarification. That's really important. There's a couple of questions in terms of the notes again and timeliness, and so I'm going to kind of piggyback them together. First, what standard does Kern have for the note timeliness for the parent? And another question here about if the clinician is helping to submit the notes with the parent and is the keeper of the laptop, but is only coming out a couple times a week, then how is the parent taking notes? Where are they keeping that, et cetera?
So Heather can answer the first part, but the second part about how the resource parents capture. So we actually take a lockbox to our resource parents where they're actually able to handwrite daily notes that have the portions broken down, like Heather mentioned, morning, midday, afternoon, and bedtime. So our resource parents actually write down daily notes of what they're doing and the interventions they're providing so that when our clinician or coach are in the home, they're actually able to review those notes with the resource parent. So they have a way of capturing it daily.
And for our time frame for progress notes is 48 hours, so completing the progress notes within 48 hours. And the reason why we created the form was exactly how Deborah just explained. We created the form so that the resource parents had the information at hand so that they could document whatever they're doing as they're doing it versus trying to remember 2 days later when the clinician or the coach is there.
And we have some questions about whether you would be willing to share that form. Would you be willing to share it?
Yeah, I'm happy to share the form. I can share anything you need. You can email me. I guess I can leave my email with.
How about you send it to Kelly, and then Kelly can post it along with the other documents with this, and folks can access it as they need to.
You got it. I will do that.
Okay, how about we just read one more question and then have you continue on with your presentation. So for the county, how many total youth have been provided TFC to date? If you could answer, there's a two-part question, so if you could answer that question for us.
So far we've provided services to 10 TFC youth.
And that's a mix of probation, wards, and dependent children of the court.
And then in addition to that, we have another 10 slots through our treatment foster care program.
And that's just 10 slots. We've had hundreds of placements in TFCO. It's been around for a long time.
Right.
Okay, thank you. Why don't you continue on with your presentation?
The next slide. So part of what we did with ChildNet when they first started was their clinicians came out to behavioral health and recovery services and shadowed some of our specialty mental health teams. So they went with some of our more intense teams, TFCO, as well as the transition age youth team. They shadowed them out in the field, watched how we worked with the kids, also how we documented those services. So they did that a few times, which I believe was very instrumental in helping them understand the process. We also have weekly meetings. We meet once a week. We discuss any issues. We go over new trainings, which I feel has been very helpful, collaborating, going over anything early on that could be potentially become an issue later on down the road. We've been able to capture those early and correct those items. So that's been very helpful, and we continue to do that. We have case consultations with ChildNet and the clinical supervisor during that meeting, as well as, they know that they can call at any time outside of that meeting if there's ever any issues, so that we don't have to wait for that meeting to resolve anything needing to be resolved. Deborah.
Okay. And the question about Spanish speaking, both our clinician and our coach are both bilingual. So our goal is to always make sure that either the coach or the clinician, primarily the clinician, is always able to communicate with our resource parents. Some of the ongoing training and support that we provide includes our resource parents working with the county systems. We constantly receive training from Kern Behavioral Health with our resource parents and our team. Our resource parents also attend weekly support groups provided by our clinician and our coach. The groups are held during the morning and afternoon so that our resource parents have options and opportunities to attend if they work or if they have childcare issues. And our TFC head of service, which is a licensed clinical social worker, also visits the home on a biweekly or bi-monthly basis to engage the resource parents on what's working and what's not working, and some of the common issues that arise in either support groups or in the homes when the LCSW is there are assessed for improvements on an ongoing basis. So our LCSW also meets with our TFC team on a weekly basis to provide that support, and is there to kind of gauge treatment, make sure that we're on the right track, addressing any issues that may have come up with the child, changes in medications, things like that.
And just to go off script a little bit, Deborah's TFC group and the TFCO group have done trainings at the Department of Human Services for our social workers too, so that they're aware of the services and can advocate for their clients.
Correct.
Next slide. Next slide.
You said next slide. Yeah.
Okay, so ChildNet has been providing the TFC services and doing the billing in our system for approximately 8 months now. As Deborah already said, to date they've served 10 children. I believe they've stepped down 1 successful TFC child. Some of the challenges has been having foster parents needing that additional support, trying to figure out how can we give them the support that they need, which we talked about, Deborah talked about the trainings, making sure that we're providing the trainings at a time that's convenient for them, not convenient for us. So if that means if it's in the evening on a Saturday or early in the morning, then we're going to do that, making sure that we have the supports in the trainings for them when we're doing them to help them be successful. Working with the partners to help them understand the services that are being provided, how to document those, and to really understand them, because if you don't have an understanding of why you're documenting it, then it just becomes another form or another task that you have to do. So that's been really an important part that both ChildNet and we, when we're doing the trainings, have really explained the importance of them documenting for everybody to understand what's going on with the kid in the home during that time. It can be labor intensive when teaching the documentation process, as Heather and Deborah have already alluded to. It's, it's very new to them. So, they're in the mental health world now and in the documentation world, where before they were able to just provide the services to the child and talk with ChildNet or talk with the behavioral health team and not have to worry about that documentation piece. Staff changes and retention of new staff, that's always something that everybody in this room has to deal with. So, making sure that we have basically, like ChildNet right now is training other clinicians in case somebody's out, to where they can step in and take over that role. And it's the same for behavioral health. We don't want a training to stop just because one person's out, so we have backup people to be able to cover those services. Lessons learned have been, TFC is serving some of the highest risk kids with success, if I can add. Meaningful opportunity for our youth to be in a family-like setting, and with strengthening their own families or long-term care relationships. System changes take time, and repetitive messaging about those changes to the system also take time, but I feel like Kern Behavioral Health and Recovery Services, DHS, and ChildNet have such a collaborative partnership that this has been, though it's been, some learning curves, I feel that the collaboration between the 3 agencies has helped reduce the pain of those learning curves.
Correct.
Deborah?
Yeah. And I just want to add that we have had success with our child, some of our kids stepping down. We had a child that received about 8 months of services in one of our TFC homes. And we partnered with the therapist to have the child's bio family, who he was reunifying with, come and start the process of engaging with the therapist, making sure that there was kind of a warm handoff, and that the bio parents and the bio family knew some of the things that we were doing successfully working with the child, so that they could continue those services with their mental health provider once we stepped out of it. Some of the challenges that we were able to overcome is getting client buy-in to services. A lot of clients have anxiety about having services, reunifying with their family members. We've had a couple of situations where we've had to really work with the therapist to make sure that the child understands what's happening next along the way, so they kind of have a big picture of what the goals are for them. Some of the things that we wish we knew before we started, some of the challenges with the system transformation and defining role in behavioral health. I think that was a big challenge for our resource parents. Probably not so much for our staff, but definitely getting our resource parents engaged and understanding their new role of not just being a resource parent, but being a therapeutic service provider. What would we do differently is maybe engaging and reunifying some of the biofamily members in the step-down process earlier. That's something we've learned along the process. And some of the modifications that we are considering, we are continually making changes in how we deliver services. Again, as Brenda mentioned, we meet with Kern Behavioral Health on a weekly, monthly basis. Our teams meet every week, and any issues that we have internally, we're able to communicate on a regular basis to get their assistance. Kern Behavioral Health is ready to step in and provide any support that we need. We've been very lucky and have had a really good relationship with them throughout this process. So far, I really feel like it's been a really good process for our resource parents to learn and for our teams, and it's been very successful for some of our children.
I think that one of the things that we've discussed as our Interagency Placement Committee, a direction that we would like to see the program go in the future is getting more homes that are willing to take some of our CSAC youth that are most challenging, and not just most challenging because of their behaviors and their tendencies, but also because of the dynamics. You really can't have other children in the home, and a majority of our foster parents have their own children or their grandchildren that are in and out of the home or have more than one foster child, and we really have identified that places other kids at risk when we co-mix CSAC youth with others. So that's a direction that I know from a child welfare perspective that we are really hoping we can build that population through TFC.
And so our recruiter, we have a recruitment coordinator that spends a lot of time out in the community going to events, and her goal is to recruit more resource parents who don't have other children in their home or who have kind of been empty nesters, who've raised their children and are really wanting to provide some type of support and service to children. So that's kind of our next goal, is where we're really reaching out in the community.
Wonderful, thank you. So Deborah, Macy, Brenda, Heather, and Jenny, thank you very much for an informative presentation, and we do have time for more questions. So what I'm going to start with is some of the questions related to your last slide, and then we'll go back to some other content from your presentation earlier. Let's see. Let's start here. If regarding step downs of TFC youth, where are they stepped down to? ISFC, to the family? What criteria you're looking for that qualifies them to step down, and there's kind of a layer of questions. You can hold all this in your head. If only 1 in 10, you said, step down successfully, then can you say a little bit about what the outcomes were for the other 9 kids and where they are? Was it just taking longer, or say a little bit about that, please?
Sure. So we have some children that have been in placement for about 8-9 months that have been receiving TFC services. So it's not necessarily that they didn't have a successful step down. They're still receiving TFC services. We've had a couple of children who have gone to an STRTP because the behaviors or the interventions just were not a good fit for the child or a good placement for the child. So we've had a couple of children that have ended up in those situations. As far as our TFC parents providing, that daily support, what we do is we meet weekly in the home for either an ICC or a CFTM that's either coordinated by the child's therapist or by the child's county social worker. Our resource parent is required to be at those CFTMs. They're almost always held in the home with the child present. And so what they talk about is what's working well, what's not working well. Does this child need to have stay in placement longer. We revisit this with everybody that's involved with the child services, the therapist, the county social worker, everybody who is providing, or the probation officer. And so we meet to discuss what goals the child has met as part of the TFC goals that were initially established by the therapist. Do we need to change some of those goals? Do we need to add more services? Do we need to add TBS? Those are things that we consistently talk about when we have those weekly or biweekly CFTs. And that's kind of how the discussion is about whether or not the child is ready to either step down into a lower level. A child can step down into ISFC, or they can stay in placement. They can also reunify with a bio-family member. So there's all kinds of different options. A lot of times they do stay in the foster home. All of our resource parents have the ability to continue placement of that child. They have the ability to adopt the child if they choose to do so. So there's a lot of options for the children once they finish and end their TFC services.
And to kind of elaborate a little bit on just the couple of kids that have gone to an STRTP, we don't look at TFC as just a step down. We also look at it as a preventative measure. So I do think that there are kids that we haven't had time to assess what their best fit is and what their needs actually are. So we do try to always preventatively try TFC, TFCO, ISFC placement prior to going to an STRTP. And sometimes the level of care that's needed is just too great, and that's at least we've exhausted every option. So I don't even necessarily think of those as failures. I think that it was a necessary step for all of us to determine what does this child actually need.
In terms of the support that's available, is there something available 24/7?
Yes, our clinician is on call 24/7. So that is something that we utilize. And also we have the assigned social worker in the home. So all of our social workers are master level social workers who are working with the child in the home as well as the TFC team. So the resource parents have support from that social worker as well as the clinician who's available 24/7.
Thank you. We have a number of questions that are related to, who's all part of this team. If TFC services is just one service within the whole continuum, especially mental health services, then, what does that whole continuum of services look like? Who's qualified to provide which of those services? There's some questions that are all kind of related to that. So what I'm going to do, and this is a big confusing thing to kind of wrap our minds around. So good questions. Thank you for sharing those questions. What I'm going to do is I'm going to toss that one over to Kim Suderman, and she's going to try to help clarify all of those different roles and qualifications of different service providers within that system. Kim?
So one of the first one is just that reminder that TFC, a provider, can be a TFC provider only and can provide TFC services with their TFC families and no other specialty mental health services, or they can, like ChildNet, also provide other Medi-Cal specialty mental health services, and that is a decision between the provider and the county mental health plan as to what those other services would be. So it differs from provider and county to provider and county, so it can be all over the map on what those other services are if they choose to do so. So I just wanted to say that as a blanket statement based on some of the questions. For you guys, one of the questions is, what's the role of your clinician that you have, and kind of how many clinicians, how many coaches do you have? I think you may have answered that, but maybe clarify. And then the different roles from the Medi-Cal certification standpoint, meaning who plays which role as head of service, as the clinical supervisor, and at providing direct services, and I think it's those three. So if you could talk about that, that would be great.
So our clinician has a caseload of about 10 children, as well as the coach. So our TFC clinician and our coach interact with the same resource parents and the same 10 children on their caseload. And so the clinician is the conduit for our LCSW, who provides, our LCSW doesn't provide direct support. She's not doing daily notes. She's not entering notes in the electronic health record. So our clinician is the main person that is working with the resource parents and the coach in providing those actual services in the home. So the head of service is our licensed clinical social worker, who again meets with our team weekly to discuss any issues that are arising, any mental health issues that we need to take back to the therapist, any medication changes, anything like that. So that is, again, on a weekly basis that the head of service is involved with our team, and they also go to the home to assess the resource parent and assess any other issues that may be arising with the child.
Oh, thank you. Let me just check. So your head of service and licensed clinician is the same person, and that person works about how many hours a week?
So our head of service, our LCSW, probably works about 10 hours a week with our team, available in the office on a weekly basis and also by phone, any of those needs that are required by the team. So our clinician actually has the 10 children on her caseload. The coach also has 10 children on her caseload, his or her caseload, and then the LCSW oversees both the clinician and the coach.
Okay. So it's 3 people, about 2.25 FTE approximately, it sounds like.
Right.
Okay. And so let's see, just checking on a couple of these other questions in relation to that's it. You don't have any other staff doing the TFC, supporting the TFC program from a clinical standpoint.
Oh, that's it.
But we do have, so there is going to be a county social worker assigned, and there's also going to be a geographical provider that's the therapist through mental health assigned. So they're not part of ChildNet's TFC team, but they're part of the child team.
Okay, so that's great. That was the next question is, so the clinician with TFC that goes out is not the individual therapist for the individual children receiving TFC.
Correct. Our role is to provide the adjunct services. So the geographical provider of the child, the therapist that they see, is we partner with them to provide that service.
And in part, that's to give continuity of care to the child. So if the child's already open to mental health, we want that therapist relationship to continue, even if they go to a higher level of care like TFC.
Right. Okay. So that's good. And that really, I just want to clarify that answers one of the other questions earlier that asked if they have to have the services from the TFC provider, and that's a no. The TFC provider can only do TFC and no other services, or could provide others. And then one other question is here, the coach, both, just to clarify. I'm sorry, say that again?
I lost you. Are you there?
We can't say it again. Didn't hear you.
We didn't hear the question.
Oh, okay. So just confirming, the coach is billing services as well. And what is the coach providing service-wise from a billable service perspective?
So the coach does provide services as well. They work directly with the child in the home, and so the TFC plan that is developed by in partnership with the therapist identifies the different skill sets, coping skills, things like that the coach is working on with the child. So whatever skill set the coach is working on with the child, our clinician is also working on with the resource parent. So there's constant communication about, say the child is working on deep breathing to help de-escalate them because they tantrum when they get upset. So the coach is in the home teaching those skills to the child, as the clinician is also teaching those skills to the resource parent.
What's the educational level of your coach?
Our coach has a bachelor's level.
So the coach is doing the coach is doing the targeted case management type services and the rehab services. So they're in there kind of doing that core case management services with the not the resource parent, but with the youth. And they're providing those specialty mental health services.
And so they're billing that not as a part of the TFC billing, correct?
Correct.
Okay. And the clinician is either doing the services under specialty mental health services or as a clinical supervisor as part of the TFC rate that you as a organizational provider is getting. The overall rate, the $65 rate, and then that rate covers the clinician's time when they're doing supervision and reviewing progress notes with the parent, and then they may do other individual services that they bill, and the coach may do other Medi-Cal specialty mental health services that they bill. So those are kind of the three categories of services that would be billed in total. Correct?
Correct.
Okay.
So thank you for all of your questions, and hopefully we were able to provide some clarification, some valuable clarification as you move forward in your planning and thinking and decision making to design your own programs. On your screen next, you will see the links to the TFC resources that I mentioned at the beginning of the webinar. Once again, these are available for free download at the CIBHS website. So that is CIBHS.org. The Medi-Cal manual and also the training resource toolkit are available also on the DHCS website. And for additional information or questions, we encourage you to use these two technical assistance inboxes. So send your questions to those inboxes. And once again, thank you to our presenters today. Thank you to Kim Suderman and to Kelly Bitts, and to all of you for joining the webinar. We would appreciate if you would take the time to answer our short 3-question evaluation as you exit the webinar. So thank you again for your participation, and I hope you enjoy the rest of your day.